Далі я хотів представити наступного спікера. Це таки буде маленька ремарочка, він нас вже очікує. Ми вчора там пригали по різних операційних. Я думаю, що сьогодні наш стрибок буде найдалі. Славного міста Токіо. Нас чекає наш колега. Це завідуючий відділенням гепатобілярної системи Сусумі Hijioka. Він спеціалізується на втручаннях ендосонографічних, про що він зараз розкаже, на гепатобілярній системі. Ну, я хотів би, щоб ми також доторкнулись до тих космічних технологій, які вони зараз мають. І ще одна маленька ремарочка. Ми з колегою, з Віталієм, були там на стажуванні 2 місяці. Я це сьогодні там біля 5 годин в мене буде доповідь, я там розкажу більш детально. Але щоб ви зрозуміли, як він відноситься до України. Тобто він надіслав свою презентацію, враховуючи, що рівень англійської трошки не всіх настільки гарний, тобто він сам перевів свою презентацію. Тобто ви уявіть, яка повага людини до нашої країни, до всіх. I'm sorry. Can you hear us? Значить, він, до речі, вибачався. Каже, що я декілька років тому я мав учнів з Росії. Вибачте, але це було до війни. Це його слова. В них відношення абсолютно негативне. Вони, є певні фінансові нюанси, які вони не обговорюють, звичайно, але співпраці явної з Росією, тобто були там на стажуванні величезна кількість людей з різних країн, всі, крім росіян. Sorry, professor. Oh, konnichiwa, professor. Can you hear us?
Hello, Dr. Olaf. Long time no seen. How are you?
Thank you very fine. Thank you very fine. Can you hear us?
Yes. Very well. Thank you.
Konnichiwa. I am glad to see you again.
Dobry dani. Thank you. I'm very glad to see you.
Thank you, Professor, for meeting. Please begin your presentation.
Thank you. So I will prepare the recording video. So could you start it? Dobry dani. I'm very glad honored to have this opportunity to give a lecture at such wonderful Ukrainian endoscopy conference. My name is Susumu Hijioka from National Cancer Center Hospital, Japan. My topic is the cutting edge of EUS-Guided drainage. First of all, I would like to express my sincere gratitude for this opportunity. And I would also like to express my deepest gratitude to Dr. Ieho, Dr. Vitali, and Dr. Olaf. And next, I would like to introduce our hospital. The National Cancer Center Hospital is located in Tokyo. We performed ERCP and EUS drainage on a daily basis in our new and well-equipped IVL center. So, EUS drainage is said to be the third drainage method after ERCP and PTCD. Professor Giovannini firstly reported on it in 2001. More than 20 years have passed since then, and EUS-guided drainage has made significant progress. Many techniques have been established in this way, like this. As time is limited today, I would like to introduce just 2 of them. First, EUS hepaticogastrostomy, EUS-HGS. EUS-HGS is a procedure that clears the fistula from the stomach to the left intrahepatic bile duct for biliary drainage. The main advantage is that it allows drainage even when the papilla cannot be accessed due to duodenum stenosis or reconstructed intestinal tract. I'll explain about the technique. First, the left lobe of the liver is visualized and punctured by the 19 gauge needle. Usually, puncture B3 is a first viaduct. After the puncture viaduct, 4 to 5-inch guide wire inserted, and dilation is performed using a drill or balloon dilator. Finally, a stenting or a plastic or metallic stent is placed for the puncture site. If the diameter of the viaduct is less than 3 mm, usually the 22 gauges is used. In this case, the viaduct is less than 2 mm, so we selected the 22 gauges needle. So successfully puncture the viaduct, thinner viaduct, contrast performed after puncture. So we can see the viaduct clearly. So after that, the guide wire insertion. Guide wire is used 0.18 guide wire when use 22 gauges needle use. After drill dilator, we inserted the metallic stent continuously. Recent metallic stent devices have been developed and improved, and the delivery system have become very thinner. So placement the stent directly following a thin guide wire is now easily possible. In recent years, in addition to EUS-HGS stenting, a method of placement the stent in the distal viaduct antegrade, so-called EUS-HGS with antegrade stenting, have been also performed to achieve even longer stent patency. And this has the advantage of creating two viaduct flow and reduce the frequency of viaduct leakage in the HGS route. This video is about the EUS-HGS with antegrade stenting. First, punctured 19 gauge left lobe and inserted the guide wire and contrast. After clearly visualize the CVD, a whole CVD visualized, inserted the guide wire to the duodenum and antegrade stenting from the duodenum to the CVD indwelling. So finally, a metallic stent press from the left lobe to the stomach. HGS can be used for a variety of applications, more advanced technique. In particular, in recent years, EUS-Guided HGS has also come to be used as a drainage method for the hepatic hilar. These are three main methods. One is EUS-HGS with bridging. The bridging method is a method of placing the stent from the right lobe to the left lobe by using generally the metallic stent and finally insert the stent from the left lobe to the stomach. In case of bismuth type 3, it can also be possible to drainage anterior and posterior using this bridging method. I will show the case this bismuth type 3. After making the HGS route by EUS-guided puncture, two guide wire inserted, respectively. And advance to the right and posterior hepatic bile duct guide wire insertion into the metallic stent anterior and posterior, respectively, like a partial stent-in-stent fashion. Recent metallic stent deliveries have a less than 6 mm, so the partial stent-in-stent method is easily performed, even in the EUS bridging method. After inserted the metallic stent in the hepatic hilum, finally inserted the metallic stent to the EUS-HGS route. I will teach a tip of how to success this bridging technique, because the left to right viaduct is very tallness from the left lobe to the right lobe. So it can sometimes be difficult to guide wire insertion to the left to right. Also even very difficult to catheter or stenting. For this reason, it's better to use a technique to insert the two guide wire first. When two guide wire was pressed, the angle of the bend became obtuse due to the force of the guide wire, like this. So after that, this makes it easier to put the stent. In our data, the stent patency period is longer with the bridging method than with multiple transpapillary insertion. Next, I would like to introduce EUS-HDGS. EUS-HDGS is a method that combines hepaticoduodenoscopy and hepaticogastrostomy, and is usually performed in the single session. The advantage of the method is the separate drainage route can be created for the left and right side without touching the tumor itself in the hepatic hilum. This is a case of the hepatocellular carcinoma HCC. The patient had the tumor embolism to the bile duct, and even multiple stenting insertion through the papilla, repeated cholangitis occurred several times. For this reason, we decided to perform the EUS-HDGS to adopt the strategy of dividing the drainage route. Show the video of EUS-HDGS. First, the posterior branch of the hepatic bile duct is punctured from the duodenal valve, and the guide wire insertion from the posterior to the CBD. After confirming the bile duct, a metallic stent is inserted. As this is a metallic stent is very thin delivery, around 6 French, dilation was not required. So a 12 centimeter metallic stent inserted. After that, EUS-HGS is performed in the same session. Puncture the left lobe from the stomach, and the same metallic stent is placed. Final figure of EUS-HDGS. I think this method could become a new drainage method for the hepatic hilar bile duct stricture in the future. Finally, we will explain EUS-guided pancreatic duct drainage. USPD is a method of puncturing the pancreatic duct from the stomach and placing a stent. It's a good indication when it's not possible to reach the papilla. The stent that is placed is generally plastic stent is selected. This is a video of EUS-PD, the pancreatic duct, which has been dilated to about 5 mm from the body to the pancreas. Is punctured with 19 gauge needle. A guide wire is then inserted and contrast media is injected. The fistula is then dilated using the Dory type dilator. Attempt is made to break through the stenosis in the pancreas cavity. The guide wire was successfully inserted into the duodenum. We selected the 6 mm 12 cm metal stent was placed from the duodenum to the pancreas cavity. Finally, a plastic stent was placed from the pancreas duct to the stomach. This procedure will be the equally important drainage method as ERCP in the future. Thank you for attention.
Professor, arigato, thank you so much. Pleasure for us. Do you have sometimes visit us? We have some questions.
Okay.
Yeah.
Dear Professor, thank you for your great report. I have a question. What types of stents do you prefer in cases of hepatogastrostommy? SAM stents or plastic stents? Thank you.
Thank you. It is very, very important and important question. So both stent can be used, metallic stent and plastic stent. However, recently we prefer to use a plastic stent because complication of the cholangitis or the liver abscess is reduced using plastic stent. However, the case is ascites. Ascites is a much increased case is at that time we use metallic stent.
And one more question. In
Yes.
cases of hepatoduodenostomy, you usually use SAM stents or sometimes plastic stents?
Yes. Thank you. Thank you. Also, it's a good question. So previously, we also use a metallic stent to avoid dislocation. However, from the duodenum to the right liver is not so move like stomach and liver. So I find it's no need to no need to fear, no need to so no need to fear the distal stent dislocation. So we usually use a plastic stent, also the same purpose to reduce cholangitis and to reduce the liver abscess.
Thank you very much.
Thank you very much.
Hello, Professor. My name is Vadim Karpyak, and I have one question about hepatogastro and hepatoduodenostomy. What segment of hepat do you prefer to puncture from stomach set or second segment? And what segment do you use for make hepatoduodenostomy? And what stent do you prefer for these operations? Thank you.
Thank you so much. And yes, the hepatoduodenostomy from the duodenum valve is we selected usually the B6 posterior segment. So the if we can puncture the more the peripheral duct, so sometimes we select the metallic stent. However, when the puncture is more the higher side, higher side. So we to avoid the cholangitis, we use a plastic stent. Decent plastic stent is very very good, better compared with the previous one. So the pushability was stenosis. Breakthrough the stenosis power is improving. So even the plastic stent, 7 French plastic stent, it can pass, it can enter. However, it's better to use balloon dilation before stenting. Thank you.
Thank you. And about hepaticogastrostomy, what segment and what stent?
I'm sorry. Thank you. Yes. Basically, B3 is better because B2 is easier to puncture. However, sometimes from the esophageal puncture, so sometimes it occurs mediastinus or sometimes a free air occur. So to safety, B3 is better. And the EUS-HGS is it depends on the operator's preference. Some doctor like metallic stent. It's better to avoid dislocation. So the case by case.
Thank you.
Next question, please. Tell me about how many operations do you have per year?
Per year, what EUS intervention?
About SGS and
HGS.
SGS.
HGS, we performed the 150 case per year recently. It is the increasing. However, the 10 to 20% of all ERCP procedure, we perform the ERCP the 1,022 40 case per year. So around this only the around 15% of the all ERCP procedure.
Thank you, Professor. It's great. I am happy to see you again. All people, all doctors tell you thank you so much. Thank you, safe for Ukraine. Thank you, safe for us. A pleasure for you.
Dr. Oref, did you perform the EUS-HGS already?
Yes, I am ready. I tell you, if I to do that, I send you. You will be fast. Who know about this?
Yes, I'm waiting. Thank you.
Thank you. Arigato. See you again.